Hello, everyone, and welcome to today's session with the title of The Noble Art of Leaving Out with Professor Dr. Probeth from Amsterdam University of Medical Center. Dr. Probeth, or Professor Probeth, is currently working in one of the largest hospitals in the Netherlands, the Amsterdam University Medical Center, as the head of acute care unit and head section of general internal medicine. Also, Prof. Bobeth has a fellowship in acute internal medicine and vascular medicine, and he is a fellow of the Royal College of Physicians London and Edinburgh, and also a board member of many national and international medical organizations. A while back in 2008, he was working as the head of outpatients department in Amsterdam University Medical Center. And he started working on the theme of reducing low value care in clinical practice. He is also doing a lot of work in these areas of, for example, antibiotics, sepsis, AI, elderly care, and acute care. I would like to leave the floor for you, Professor, if you would like to add anything for our speakers.
Thank you very much for your kind words. Thank you very much. And it's an honor and a privilege to be here. So, as you just heard, I'm the professor of internal medicine at Amsterdam University Medical Center. My topic is noble art of leaving out. So, what will I talk about? When it comes to testing, we know that this is a review which was published in 2013. About 20% of the tests, now I'm talking about the laboratory tests, are probably in retrospect unnecessary. In retrospect. Why do I say it's unnecessary? Because the result does not contribute to clinical decision making. It doesn't contribute to diagnosis, to prognosis, or monitoring. And there is also a school of thought that the tests are being underutilized. They're underutilized. How many percent of the tests do we use the tests we have as efficient as possible? Unfortunately, we don't know that because there have not been many research on this subject. But I will talk about it later when I especially talk about our algorithm tests. And at the same time, if you look at this, you see curbing unnecessary and wasted diagnostic imaging. If you can see you see here, which was published in JAMA. They also say, if you look at, for example, US use about 3 to 4 times the CT scan, number of CT scans or MRI scans, what Finland use. Population is just as rich, the countries almost just as rich. So there's a difference in use. And also there have been many research projects which shows, for example, if you look at trainees in internal medicine, some trainees use 5 times as many tests as other trainees. And if you look at their outcomes, it doesn't look much difference. And we have been speaking about this for a long time. This is a study which was performed in my hospital in 1985 by one of my colleagues then, who was a young student who just took away 100 charts, patient stats when they were discharged, and just examine how many tests were performed and what did they contribute to decision making. 30% did not contribute to decision making. So I will, in the coming 30 to 40 minutes, I'll talk about our RODEO project. This project is called Reduction of Unnecessary Diagnostic through Attitude Change of the Caregivers. This was a project, part of the To Do or Not to Do project, reducing low value care. This was a national project, and we were one of the arms of that project. And also later, I will talk about our work on AI algorithms, artificial intelligence algorithms to augment diagnostic and clinical decision making. And the trial, which is ongoing at the moment, ABC trial, I'll talk about it later. So this is long time ago. This is 2008. This we were not merged. We are merged now, two big hospitals in Amsterdam, but this is called VU University Medical Center. When I was the head of the department of outpatients department, during clinical meetings, I noticed that young doctors especially did lots of tests without exactly now thinking about it. I mean, I know, and then also I knew that every doctor, every nurse wants to give optimal care. Nobody wants to give bad care. So one day I saw a patient whose cholesterol value has been determined 26 times in 2.5 years. I was thinking, why? So we were just thinking about it, and I talked to one of our advisors. She was working for the business intelligence, and we thought it's probably on the one hand, it's a routine. We are used to what we do. On the other hand, we want to be 100% sure. So when you're young, when you're not that experienced, you have tendency to order more tests, and that routine you keep the routine, and when you're older, you sometimes do the same thing. So we thought, can we change attitude, change thinking, and change behavior of our colleagues? So we started a project just in a small room like this, and then we thought, what should we do? We thought we should intensify supervision, especially for our young doctors. And we advised the supervisors, the specialists, not only to concentrate on diagnostic reasoning, but also on not on clinical reasoning, but also on diagnostic reasoning. We created mirror information, and every 6 weeks we went back to the department and showed the doctors what they did, without saying anything. Only asked them, did it help? The test you did, why did you do so many tests? And we concentrated not on expensive tests we do rarely, but we concentrated on cheap tests which we do very often, like sodium 40,000 times in our hospital, blood urea nitrogen 30,000 times. I could not imagine why we should have that test for 30,000 times in our hospital. Potassium. And also, we send them reminders about our projects, and we use clinical discussion moments such as the morning handover, the grand rounds, to ask questions about their decision making about the diagnostics. And what happened was, and then we measured for a couple of months what they did. We started somewhere around 2008, 2000, halfway 2007, 2008, and you see what's happening. We were planning to reduce the diagnostics by 5%, and they were reduced by 13% in that year when you compare to 2008. And the maximal effect was seen in laboratory tests. Laboratory tests were reduced by 21%. And these are charts of individual tests, I mean, lots of individual tests were also reduced significantly. And we published that. And also at the same time, we were looking at clinical outcomes. What's the in-hospital mortality? Or what's the readmissions in 30 days? There were no changes in the outcomes as much as we could measure it. So our conclusion was, when you talk to doctors and nurses and make them think about why they do something, the diagnostics get reduced. Probably unnecessary diagnostic. Hopefully about 95% of this diagnostic, maybe more, is unnecessary. And we did the project for about 2 years. And then it was a very intensive project because my colleague from the business intelligence and one other doctor, we were going through, we were talking to the doctors all the time, internal medicine. What happens was other departments also found out that we were doing this, and we were invited to visit the other departments and tell them what we did, and which led to more reduction in diagnostics. For example, pediatrics reduced total diagnostic volume by about 25%. They concentrated on lab tests, but you could see that the microbiology was decreasing, the radiology was decreasing, and people were getting conscious about the low value care, and they were reducing it spontaneously. And we let it go after that. And we only sent every 3 months to the department in the coming years, departmental heads, what their department was doing in the last 3 months. And then we measured it 6 years later, and it never went back to the zero value. The reduction persisted in spite of the fact that we took a little bit of gas back. So what happened was the media picked it up in the Netherlands. We had lots of interviews. We had to give lots of talks. Resulted in that we were forced to also go on doing this because we also saw that people were adopting our methods. One of our PhDs, Dr. Bindraban, Renuka Bindraban, she did lots of work on this rodeo project. She wrote a review in 2018 where she studies 84 studies. I must say the studies were of medium value. They were not high-class studies, randomized control trial. She looked at interventions to reduce unnecessary diagnostics, divided into 4 categories: education, computer-provided order entry interventions, audit and feedback, and other interventions. The conclusion was the interventions help, but not much. Individual interventions always help, but not to a significant degree. When you combine them, then the effect is much larger. And eventually, what you should focus is on the change in the behavior and mindset change. So when you talk about something, if you can make people think, then they come up with their own solutions. And that's the message we got. And this resulted in so-called Rodeo project. It's a national project where we got hold of 4 large hospitals, very large peripheral hospitals, and we thought we are going to do exactly what we did in our university hospital there. And these were very large clinical hospitals. I'm sorry, this is in Dutch, this slide. This is a mouse pad we developed for this project. In this mouse pad, which we distributed to every computer in 4 hospitals, we had 3 questions. Has this the test results any consequences for the patient? Should you repeat this test now, or can you wait? And why do you? Well, is a combination of tests needed, such as SGOT, SGPT, creatinine, urea, BUN, blood urea nitrogen, sodium or potassium. So we just kept asking questions, and this was a mouse pad, and we had posters developed and lots of stuff to get them going. So how did we start the project? The idea of the project was we're going to do this multi-step intervention. I'll discuss the intervention in a few moments. And we are going to get 2 teams. The central team, that was me, Dr. Bindraban, and Malu from Beneda, who was our business intelligence advisor. And every hospital has their own team, which contain business controller, laboratory specialists, very important, section head as nurses, and also young doctors, especially in training, an experienced clinician as a local champion. The launching was done on 29th, a long time ago in 2016, in the Olympic Stadium in Amsterdam. Olympics were held in this stadium in 1928. We want to just give it publicity so that people will think about it whenever they hear the name Rodeo Project. And what was the intervention? So that's how we started. The interventions, we had educational interventions, clinical lessons, frequent clinical lessons, especially about diagnostics. What's the value of amylase in diagnosis of pancreatitis? What's the value of lipase? Such lessons were given. During the ward round and during the clinical morning handover, questions were asked about what has been done. Why was this CT scan performed? Did the patient get better with the results of it? So, but at the same time, what we told them was, do whatever you need to do, but try not to do what is not necessary. And we also wanted to make them cost conscious. That's a bit difficult because the cost of the test, not only the cost, there are more things which decides the cost also. 24/7 the labs has to be open, 24/7 the radiology has to be open. But we just want to show them how much does all these tests cost a year, and how much is a single test, and if you reduce this, how much money would you save? But we did not put much emphasis on money. We put lots of emphasis on quality of care. We looked at the order systems. We look at order sets in our Epic electronic patient notes, and we made the orders opt out, not we opt in. Sorry, not opt out. So if you need something, you got to actively take the order, not actively take the order to get it out of the order system. So it became opt-in order systems. We had redundancy checks. Should you repeat ESR every day? Should you repeat CRP 2 times a day of every day? When should you repeat B12? When should you repeat TSH? So redundancy checks. And we also look at the frequency of testing. When a patient gets admitted, that there are some doctors who do tests every day. Said, is it necessary? Why don't you do 3 times a week? And unless you have an indication. Clinical chemist was invited to morning rounds, and then he gave lots of talk and also gave his comments on tests which we use. Local champions were used just to inspire people. And also we looked at the outpatients department and looked at the frequency of visits to the outpatients department. And also we asked the doctors, you want to see a patient, do you always need to do the labs? Maybe you want to see the patient for something else, then don't do the lab, or try to decrease the frequency. If not, if necessary, you got to see them, of course, as often as possible, but think about what you do. And the feedback, the mirror information, test volumes. Every 6 weeks, we show them what they have done and ask them questions. And if we saw some deviations, for example, we saw in given period, there were lots of PET scans, we were asking them what happened. And then we found out that they were doing research with it. And asked them not to do it, but only do clinical care. For research, different way to do it. So monitoring reminders, this was the intervention, and this was fairly intensive intervention. And Renuka Bindraban, one of our PhDs, and also Malufam Beneda, they also visited most of these hospitals frequently to talk to the local teams. This is the methodology. We had a pre-intervention period of 3 months, hospital 1, 2, 3, 4. Intervention periods, one hospital started late, of 6 months, and then we measured what was happening. We were measuring all along. And during the morning rounds, there were young fellows who were giving lessons. That was a part of their education. That was a part of their fellowship. And they were instructed also to choose relevant topics relevant to this project. Now, this is a talk on blood cultures. How does blood cultures help us or not help us? I'm coming back to that later. So this is information about the hospital. They were big hospitals with 25,000, 30,000, 54,000 outpatient clinic visits. For Holland, they are big hospitals. For US, not. They're much bigger. But the Dutch hospitals are fairly well organized and not that crowded. So what happened? What we see was there was a reduction of 11.4% in total diagnostic volumes in these 4 hospitals average. We also used 19 other hospitals which were not in the project and just looked at what happening there. In other 19 hospitals, there was an increase of 2.4% of the test volume. So in our hospitals, especially the lab, went down by 11.4%. Other 19 hospitals where we did not work, it went up by 2.4%. And there was a significant changes in slope for laboratory cost and volumes and for other diagnostic procedures. And we also look at the outcomes such as mortality, more admissions, length of stay, readmissions. Nothing changed. So it looks like we could reduce this volume of diagnostic without changing the patient outcome. Of course, it's possible that we have, this was not a gold standard way of measuring it. There was no gold standard way, and also we looked at patient complaints did not increase. Everything remained the same. This is a hospital 1, 11% reduction, hospital 2 only 6%. This was not significant. The hospital 2, the main reason was the clinical local champion who was involved was not intensely involved with the project, but the other three hospitals did. We could see significant changes, and if you look at the total, there was a significant change of 11% reduction, and this is the 19 other hospitals with 2% increase. And one of the things we saw was you need to have lots of patience, because when we started here in the first couple of months, nothing happened. We were working hard trying to get it done. Nothing happened, and you see that here. But suddenly after about 7-8 months, things started changing. The test volume decreased and everybody was with us. So you need lots of patience, you need lots of persistence, and you need lots of perseverance to hang on to this and get the results you want. And at the moment, we have also done some tests to see whether this persists now, after stopping the project. It is still there. We see that in 1 or 2 hospitals where we looked at the reduction persists and with little intervention, but it's coming up a little bit. What's happening to Harpoon principles now? Many hospitals in the Netherlands are taking over our principles. We have made a blueprint of what we did, and that is being used at the moment in many hospitals to do the same thing what we did also in their departments of internal medicine and outside. And we, one of our current PhDs, Rose Burman, is helping them also, and we get lots of questions frequently about this. We also talk to the doctors and nurses about facilitators and barriers. Facilitators was if you have the insight in orders. And one of the things we were scared of was the doctors would be offended if we just show them what they do. So we were always talking about the collective, but at a given moment, doctors want to see their own performance. They want to compare it with their friend, not out of jealousy, but to learn from each other. So insight in orders is pretty important. Education and background information. The people found that really important to do a project like that and to reduce unnecessary diagnostic. Active supervision, you need local champions if you want to change the mindset of especially young doctors. And when you change their mindset, they persist and they take the message to other hospitals. So what we found was the young doctors who saw our project, who were involved, when they went to other hospital, they took it with them. And repeat frequency, especially what we see was when you reduce the repeat frequency, when you reduce not everyday labs, reduce it to once in 3 days. If necessary, you can do it 3 times a day, but otherwise once in 3 days. The visits to the outpatients clinic, that has much influence on number of tests which were done. The barriers were too much focus on cost. Let's say you focus on one test and you find out that it costs 30 cents or something. And if you reduce 10,000 of these tests, it doesn't save much cost. But you should remember that when you work on one test, people start thinking also about other things. So there's collateral damage or collateral improvements which comes with it. So in the beginning we were talking about the cost, but later we talk about patient safety and also not harming the patients. There was a problem with high turnover of young doctors because we had appointments for 6 months and they move away. That was a barrier. And of course, the time constraints. So this was a very large project, but also intensive project, which we created. And then came the question, and lots of people work in our project. And then came these are all the hospitals who worked in the project. Then came the questions, how can we now integrate this into day-to-day routine practice? And therefore, we thought we're going to choose one theme which we were working on in the last 10 years and see whether we could use artificial intelligence to do that. This is current practice. If you're a doctor, you know there's a strong recommendation from Surviving Sepsis campaign. When a patient comes with a systemic infection, or whatever you call it, sepsis, you got to take blood cultures, give antibiotics. This is a strong recommendation, but if you look at the quality of evidence, that's not much. So that's why we did a large study in the ambulances called Fantasy Trial a couple of years ago, and gave antibiotics to the half of the population in the ambulance, other half at the ED, and showed that not everybody needs antibiotic as soon as possible, and there's lots of antibiotic usage, about 30% at the EDs, because they're only viral infections. So during the project, one of our PhDs, Rishi Anand Pandey, looked at the blood culture results. He looked at 5,000 patients. I'm going to explain this. You don't have to read the whole slide. 5,000 patients who the cultures were taken, and we found out that from the cultures, 5,000 patients, the cultures were taken, 85% was negative. And from the 15% positive cultures, according to the international standards, 50% was contaminated. So eventually we had about 8% culture positivity. The results come after 48 to 72 hours. Very little influence on the patient care. We give antibiotics anyway, broad spectrum antibiotics. And on the basis of culture, sometimes we adopt the antibiotics and change it, not always. So what we thought was the blood cultures, majority of blood cultures are negative and does not contribute to patient care. I know it's a simple way of thinking about it, but this is the reality. And at the same time, we were thinking about artificial intelligence. These are our publications written mainly by a guy called Paranape from USA, and also Michael Skinkel. And they were doing research on why can't we integrate AI in the clinical practice, while banking systems and many other areas are using it so intensely. We in the medicine lags behind. And that's how we worked on the last couple of years and started the study called ABC trial. I'm going to show you a film now about the ABC trial and explain it later. Okay, so I hope you. So what did we do? The algorithms. We developed an algorithm at the ED to predict the positivity of blood cultures. What is the chance of the blood culture getting positive? Our aim was to reduce negative blood cultures, so from 85% to a certain level. I'll come back to you. We developed the algorithm using so-called gradient boosted tree technique. I'm not going to go into it in detail. If you want to read about it, I'll show you our publications. You can read it there. And one of the advantages of this system is you could see what are the predictors being used to predict the chance of positivity of a blood culture. So when a doctor orders the blood culture, we use the algorithm to predict what's the chance of this blood culture becoming positive, and which factors are involved in this prediction. If you look at it, we asked the computer to come up with it, and the computer came up with these factors: temperature, plausible; CRP, plausible; lymphocytes, plausible. So you could see most of these things which the algorithm used to predict this positivity were plausible and explainable to a doctor or to a nurse. How did we develop this algorithm? In my hospital, VUMC, we used a test set of patients who has undergone blood cultures, who had positive and negative blood cultures, to develop this algorithm. You see, that's the first column. Sorry, that's a validation set, part of the data, and then we use also a part of the data in the VUMC to validate the algorithm. That was the internal validation. And then we went to 4 other hospitals and got their data. AMC, our sister hospital, a medical center in a nearby region, an international database from US, Boston, and another hospital far away from our region. So they were quite different hospitals. So our hospital, we created the algorithm and validated it in a test set. And then 4 other hospitals, we went out and tested the algorithm. And here you see how it performs. So how it predicts the positivity of blood culture. It had an AUC of about 0.8. This is in our hospital. And we tested in other hospital. It was not losing any validity, which means that we could use this algorithm to predict the chance of blood cultures and advise the doctors not to do blood cultures eventually. And what we did was we had focus groups with doctors and nurses, and we explained it to them that we do lots of blood cultures because we are scared to miss serious infections. And we use about 30 to 40%, there's about 30 to 40% overuse of antibiotics. So we want to first reduce the blood culture and maybe in a later stage also see whether we could use these techniques also to use antibiotics. So what we asked them was, if you give you with certainty, which percentage would you choose not to do blood cultures? With lots of discussions, we became very conservative and we said, if the chance of having a positive blood culture is less than 5%, we're not going to do blood cultures. And the rest of the patients, we could do blood cultures. And we also evaluated it prospectively. But when we do that, we build the algorithm in our system and then did not tell the doctors or nurses that the algorithm was running. This was allowed by medical ethical committee, our ethics committee. And we also validated the algorithm in day-to-day practice, and it was still performing pretty well with the area under the curve of 0.8. And if we use a threshold of 5%, we would lose 4 positive blood cultures, but prevent 303 blood cultures, which is about 30%. We looked at these 4 missed cases. Most of the patients, I was not very sure whether the pathological agent which was found contribute to the process, and the 2 other had positive urine coag. So these 4 missed cases did not influence the patient care if we did not do the blood cultures in these 4 patients. So the message is, if you take a threshold of 5%, if you use the algorithm in day-to-day practice at the ED, in a patient where a doctor wants to do a blood culture, and if the algorithm says the chance of positivity is less than 5%, you can just omit the blood culture. And we also tested how the algorithm performed over time, a couple of months, and the algorithm is performing pretty well through the time period, which means that we could integrate this algorithm in our EPIC, our electronic patient record system. And when a doctor orders the blood culture, he gets one of these screens immediately, automatically. One says 4.38% chance of positivity, then we cancel the blood culture. And if it's 9%, the blood culture goes on. And we want to test this in practice. That's why we are doing the so-called ABC trial. We have published the protocol in BMG Open. We got the first three names. They are our PhD students who are coordinating the trial. What do we do in the trial? When a doctor says at the ED, I want a blood culture, he gets a pop-up immediately. Think about the trial. Does the patient as suits the trial? So in the exclusion criteria is given. You can see, can the patient go into the trial? Exclusion criteria are mostly catheters, intravenous catheters, which can cause other kinds of pathology. And then the doctor asks for informed consent. And then we have built in the EPIC automatic randomization. Patient is randomized to either control group, where the whole process continues, or treatment group, where the algorithm advise the doctor not to do a blood culture if the chance of positivity is less than 5%. The study is running now. We hope to get the results maybe in the coming 1.5, 2 years, and after that implement it, and also implement it nationally, hopefully. So this was a way to continuously stimulate people to think about what they do. And what we hope is, if we do this with blood cultures, maybe we could build algorithms for other tests also, test groups. But however, when we do this, we know that the doctors will think about other unnecessary tests also. So you will read about this hopefully in the future. So I have spoken, and you can read all this. These are all publications which we did in the last 5 years. Why did we publish all the processes? Because we want to build up an evidence-based database, practice-based evidence, so that we can use this in integrating rhythms in the day-to-day practice to reduce also unnecessary and low-value care. So I've spoken in the last 40 minutes, and I've shown you that probably 20% of the lab tests are in retrospect redundant. Same applies to radiological tests also. With our multi-step radio intervention, we reduce the total laboratory tests and also total volume of tests significantly. Most of the reduction was in lab tests, but the radiology reduced, microbiology reduced, nuclear medicine tests were reduced also significantly. And the intervention was really really complex. So we need a way to integrate the intervention in day-to-day practice, and we have started using AI augmented algorithms, AI augmentations with algorithms to facilitate decision making in doctors and make them think and reduce diagnostics. And this is my talk. I wonder whether you have any questions. Thank you.
Thank you so much, Professor Prabeth. We're going to be waiting right now for people to put in their questions in the Q&A section. So please, if you are listening to me, write down your questions in the Q&A, and I will read them out loud so Professor Prabeth can have the opportunity to answer them and answer all of your questions, comments. So as we wait, Professor, I have actually some questions in mind, if you don't mind answering them. So first of all, thank you so much for the informative presentation. I really enjoyed the presentation. It was a lot. I think we need more time to unpack because it's a lot of information, and it's really interesting to see what you have done in the area of sepsis and also the antibiotics and the algorithms to help doctors, reduce waste in unnecessary testing, and to help them also in deciding on a diagnosis. So my question is, Professor, is there a part where patients were involved?
Yeah,
and this
yeah.
project and reducing tests? Because some patients might be upset and they might go to the patient experience department or patient relations and file a complaint like, I need this. Why would you deny me this test and so on? So what was the approach here?
Very good question. Very good question. We didn't involve the patients in the beginning, but later we involved them also. And of course, there were some patients who were skeptical. But when you explain them, especially when it comes to blood cultures, I didn't say that contaminated blood cultures cause more downstream diagnostics and also a longer length of stay, more a test, and even higher mortality. So we could explain to the patient, if you do test without thinking about it, it may cause, there's always 5% chance that a test is uh, uh, um, not normal because the tests are mostly 95, about 5% of the patient's population falls below to that two standard deviations. So we explain it to them. You see things you don't want to see, and it may harm the patients. And when you do that, they go with you. And also algorithms, we have spoken to patients, and we are in the process of involving them more intensely. So that's a good question. In the beginning, we didn't involve them. Later, we really talk to them and ask them for advice also.
Okay, thank you so much. Another question in mind is like, what inspired you to start this algorithm? Because I know it was a lot of work to integrate, AI and have the smart, algorithm pick up on certain, phrases and then integrate it into the system. What was the inspiration behind that? Because I know it takes a lot of work and a lot of convincing and basically buying in from leadership to get you to where you can, and a lot of money, I'm sure, to get this started.
Yeah, we got I'm fortunate to have some very young, inspiring people around me who also work on these algorithms. And we had a problem with the rodeo project. It was so intensive. We had to go and visit hospitals so often. We thought we have to have a way of doing this in a different way. And then the algorithms rhythms were coming, and we were thinking, okay, maybe this is a moment to integrate it in the electronic patient records, and then continuously remind them of what they do. And that's how we came into algorithms. And in the beginning, we were thinking about creating algorithms to predict readmissions and representations. But at a given moment, we thought the blood culture algorithm would be more helpful. So that's how we started working on it. And our team, we believe that algorithms, if you want to integrate in day-to-day practice, you got to treat them also like integrating a medicine. We do lots of research before integrating medicine in the day-to-day practice. But when it comes to algorithm, there have been 29,000 algorithms published in the literature. Less than 0.5% is used. So what we want to do is usable algorithms, and then use them to remind people of what they do. That's how we came to algorithms.
Okay, so basically, it's like you mentioned, it's a lot of, in-depth research, evidence-based practices to back, this intervention up
Yeah,
in order to integrate it.
yeah, you got to have evidence based. That's why
Mm.
we have a very dynamic team. One of my postdocs, Mikhail Skinkel, and most of this publications, he was the first author. And then, I mean, every step we wrote and published, and which also stimulate critical thinking among us. When you publish, you got to be critical about what you do, and that's how we developed it. And we'll be going forward in the coming years on this team, and Dr. Bahirat and two other, who's also here, I think, two other PhDs are working on this team further.
Amazing efforts. And also, I have a question in mind as you were reading out loud. I would like to ask you of like the way that you started, engaging those physicians? Because I understand that, you might face some, resistancy from some physicians in the practice because, they've done it so long in a certain way, they would not like to change their ways. So what did you do to engage those, providers and spread awareness of this new algorithm, the new way of doing things? Because I
Yeah,
know that takes a lot of effort and a lot of awareness campaigns.
that's a very good question. So what happened was when we started off, most of the experienced clinicians said, no, I don't do anything unnecessary. I do tests which is only necessary. We did not go into discussion with them. We told them, can you supervise your young doctors and teach them what you do? And in the process, they had a discussion. Suddenly, the experienced clinicians realized, oh, I do this also. So it was in the beginning it was difficult. Some people were not happy at all. But when we started it, and especially the young doctors, they said, okay, this is something which we have to learn. And when they become enthusiastic, the elderly doctors, they had discussions, and suddenly they changed also. And the algorithms, the funny thing in algorithms is, um, all doctors, the experienced doctors, they love this. They all want to just take part and discuss about with us about this algorithm. So that's something different which we didn't expect. But in the beginning, we had lots of problems with experienced clinicians because they thought we do everything right. So you got to have lots of patience, especially get young doctors involved and make them ask questions also. Then they'll change.
Thank you so much. We have a few questions here. I would start with the first one. It says, what are the clinical parameters that the research team of Dr. Nania collect other than the patient body temperature? And does this software in the business, is it for sale for, medical biotechnological companies or not?
No, we, one of the problems with algorithms is that many people develop algorithms and they ask for patents and they want to start a company and sell it. We don't believe it. We think that we have to first come up with the algorithm, integrate it in the practice, and show that it works, and then go commercial with it. And so we have been very open with our algorithms. We have been very open with our clinical questions. If somebody wants to take over and make it better, be our guest. So no, it's not available commercially, but if you want to work with us, please send us a mail. We'll work with you. Anybody can work, anybody who wants to come and work with us, talk with us, more than welcome. I mean, you have my email address. You can also share it. You can share my presentation. And our PhD team, they're really enthusiastic people, so they will work with anybody. And we don't do it for commercial. No.
Oh, not commercial. Okay, thank you so much, Professor. We have another question. It says, what was the predicting factors for sepsis in your algorithm that you've used to reduce unnecessary blood cultures? If you can mention that briefly, and did you get the results in identifying the septic patients versus the non-septic ones?
No, that's a different. In the algorithm, you get temperature. You even get urea, which is also in SOFA score. You get bilirubin, which is also in SOFA score. Creatinine is also there. What we did was just purely ask the computer to come up with algorithm on the basis of vital parameters and labs. Of course, you get free text, which can be included, but we do not do it because of the privacy aspect. The question about sepsis, we have done lots of work on sepsis and also about golden hour and all that. Unfortunately, it's a complex question to discuss now. But the person who asked the question, if you send us a mail, we will give you an answer and also send you our papers on that. It's a good question. Sepsis is a concept. In our opinion, we use use the diagnosis of sepsis too often and give antibiotics too often and too quick to patients. I'm not saying that patient with sepsis, septic shock, or severe sepsis should not get antibiotics. Definitely not. But what we say is that you got to do a prognostic profile and maybe take some time to think about the disease in some of these patients. So your question, we have used vital parameters. The concept of sepsis is a different concept. I didn't talk about it now. It's a long answer. If you want, you can send me a mail. We will talk about it.
Thank you so much. That was really helpful and insightful. I liked some of the questions. Like, I'm very intrigued, actually.
Thanks. I don't know whether they have more questions. I see some hands being raised.
Yeah, I see. Yeah, there's more questions. So I have a question here. It says, like, for the purpose of like enhancing healthcare quality in general. So can we use like such projects as supplementary projects to involve, clinical inspectors, for example, in monitoring and for sustainability purposes? Can we use the algorithm or similar projects for such uses or not? Would you recommend them?
Yeah, I would recommend them, but you got to be very careful. Algorithms can be used and misused. So that's why you got to first test it profoundly and see. And benchmarks between hospitals and even between doctors is a good way. As I told you, you got to do it in a way that you don't complain about somebody doing lots of tests. You got to just talk with the person and show them that there's another way. So yeah, inspectorate, I don't know, but most of the hospital directors, I knew that they were intrigued by our results and they were talking to their own doctors about these results and advised them to talk to us and work with us. So yes, you can use it. The administrators can use it. Benchmark data can be used, but you've got to be careful not to benchmark. Patient populations can be different, so it can be used, but it should not be penalized. If somebody this to me, of course, if they do it for money, that's a different thing. So you got to be careful with that. But my experience is, lots of doctors want to know how well they do, and if they know that there's something which can be improved. I have never met a doctor who doesn't want to do that in last 15 years.
Thank you so much. And one last question, if we don't have anything from the participants, I would like to just ask one more question. So about starting the project and aligning those international and national initiatives, which are like they're almost as huge as initiatives, not just as improvement projects. So how did you find a way to fit in these projects within the system itself on a bigger scale, not as part of a hospital system, or I'm talking like bigger levels, like a government level or a national country level.
Yeah.
How did you find that, path towards fitting in this piece into the system?
Yeah, we started off in a small room with two people without not knowing that this would go so far. And when we started off with one department, internal medicine, suddenly the whole hospital was talking about it and they were adopting our system. And then the media started talking about it, and then we did some interviews, which means that other universities got interested, and the central committees which give grants to do research got interested. So we were lucky in that way that we had lots of positive results, which we spreaded in a way that it influences policymakers. And I would advise you try to do one or two large projects nationally than to do 50 projects, small projects, which will not give you proper answers, So I think we started off in one hospital. We created lots of positive results. That created lots of publicity. Other universities got involved. And then we asked the policymakers to concentrate on this, about the unnecessary diagnostics. And now it's being spread also to the other hospitals. And that's how we started. So I would advise, try to do projects which are large, to include enough patients and enough doctors.
Okay.
Don't do
Okay, so
small
you
hospitals.
so you're saying grow like organically in a
Go
way.
organically, yeah. And I mean, if we can help you, we would help you. We have
Hmm.
most of this. We have even created a blueprint of our project. It's in Dutch, but we can translate it to English and
Hmm.
then share it also. So go organic and start it, yeah, and also get patients involved from the beginning.
Hmm.
Let the patients also talk about it, and because it harms patients also. Too many diagnostics.
Absolutely. Okay. So, what would you say is the number one thing that we can focus on as, let's say, I'm a person who's interested in taking this on a national level. What can I do, like the first step, like tomorrow, start it?
Tomorrow,
What would you recommend?
I would talk to the clinical chemist and come up with a plan to reduce unnecessary lab diagnostics.
Hmm.
And then from there you take it to the radiologist and all that. But talk to clinical chemists, get some national leaders, respected clinicians, and sit with them. And you need one or two. Some people won't believe it. That's a problem. You need some people who believe in this. You have enough evidence that this is happening, and so get one or two clinical leaders and get some clinical chemists, and let them talk. And we are going to do this probably in one region in UK, in Winchester.
Hmm.
And we went there and we talked there. What we did there was just give a talk like this, and then they were interested, and from there we took it.
Amazing efforts, looking back at your biography and looking back at your work, throughout the years, it's amazing, honestly. And it's, a pleasure to have you with us here. And if there are no more questions, I think we're almost out of time. We have 1 minute left. Let's see if anyone wants to ask one last question before we end the webinar. And for me personally, I would like to thank you, Professor. We've learned a lot today, and like you said, it's a new school of thought, it's a new way of thinking, and it's a method of the future. And we're all working here to learn from the best and also adopt what's working in other systems, and um, tailor it a little bit to make it work for our system and our people's needs as well. So it's really a pleasure to have you here and learn from you. And also, a lot of people are saying, it's a brilliant lecture and we've learned a lot. So, from the family of Saudi Patient Safety Center, we would like to extend you our thanks and our gratitude. And hopefully, this won't be the last time that we host you. And we would love to hear from you more in the upcoming future. And you have a wonderful evening.
Thank you very much. Thanks for the invitation, and keep up the good work. And if we can help you in any way, please let us know. We are open
Thank
for
you.
discussion. Thank you very much. Thank you.
Thank you so much. Thank you, everyone,
Thank
for
you. Bye bye.
attending. Goodbye.
Bye bye.